Hello, I'm Dr. Howard Hoxter from the Yale Cancer Center, and we're talking about the Oncotype DX colon cancer assay. We were just discussing staging for stage 2 colorectal cancer and the risk factors we use to determine high risk versus low risk. With me today are two of my colleagues, Dr. Deborah Nagel and Dr. Darren Wheeler.
I'm Deborah Nagel, and I am the Chief of Colon and Rectal Surgery at Beth Israel Deaconess Medical Center in Boston.
And I'm Dr. Darren Wheeler, the West Regional Anatomic Pathology Director for Quest Diagnostics.
So we've been talking about stage 2 colon cancer and how we can prognosticate today based on the pathologic findings. I'm always somewhat concerned about the way we prognosticate in stage 2 because it's not too accurate. I mean, we're basically, when we stage colon cancer, we're kind of relying on this 19th century microscopy technology, and you'd think we could do better in the 21st century, but we still go back to things like nodal involvement and then the secondary features of grade and lymphovascular invasion in addition to the clinical features such as perforation. So, Dr. Wheeler, when you read colon cancer, I mean, how do you grade this and how do you try to convey the risk to the clinician?
Yeah, so if you look at the NCCN guidelines as to what are, quote, high-risk features for stage 2 colon cancer, I think pathologists are much better now with much more awareness and doing their due diligence at identifying a number of lymph nodes in cancer resections. And we all know that we want to find 12 or greater lymph nodes. And I think we're doing a better job at doing that. And it's certainly very important to accurately stage the patient. And I think that we're pretty good at identifying, bowel obstruction, bowel perforation, more things you probably even know clinically. So finding those T4 patients in that stage 2 category, would indicate some level of high risk for providing adjuvant therapy important. But as you said, when we get down to other things like grade, like identifying lymphovascular invasion, we're not very good. And so, I think that if you see a lot of lymphovascular invasion, usually in a patient that you're trying to stage, you will almost always find lymph nodes are also positive, taking them out of that stage 2 category. So we're talking probably a very small percentage of stage 2 patients where you're going to identify bona fide lymphovascular invasion. And so, as you said, for I think the oncologist or the surgeon to hang their hat on the histopathologic findings at this point, I think is questionable, and certainly we're in need of better markers to help identify risk in stage 2 patients.
So you routinely report the number of nodes, the grade, lymphovascular invasion present or absent, and any other features?
Yeah, perineural invasion is also one that I think there's less subjectivity on perineural invasion. I think we're better identifying it. But again, it's in a minority of stage 2 patients, but that also would indicate an adverse prognosis. Grade, there's been numerous studies to show that in the large trial data to suggest that high grade does not denote a higher risk tumor. There is some literature out there that suggests that when you pair it with MSI tumors, it has much more power, so that a high grade microsatellite stable tumor may have more indication for a high risk behavior than those that are obviously microsatellite unstable. So I think that there's kind of evolving literature to suggest that maybe we're going to change our grading down the road to incorporate microsatellite instability, but we haven't done that yet.
I see. And Deborah, what do you contribute to the staging and risk assessment from the surgeon's point of view?
Well, the clinical features intraoperatively can often be helpful, and if there's suggestion of T4 disease with invasion of other structures or invasion into the retroperitoneum, something that tells us that tumor is not freely floating in the abdominal cavity, that's a source of concern. Obviously, obstruction and perforation amplify the level of concern, and those are our main features. We also obviously look for large lymph nodes or any palpable or visible lymph nodes in the field, and what we do is actually tag those, because what I've learned is that the lymph node sampling does not necessarily start at the level of the tumor and proceed outward. It can often start at one end of the specimen and simply work to the other end.
I see.
So sometimes I'm not even confident that even though we have an adequate number of lymph nodes, the best lymph nodes have been sampled. So identifying those things, clinically at the time of surgery, I think can be helpful.
So, I mean, even if you go back and look for more lymph nodes and you come up with fewer than 12, because some people actually do have fewer lymph nodes, the number seems to perhaps reflect some kind of immunologic factors in the patient itself. I mean, what do you consider that a high risk in and of itself? I mean, how do you
Yeah.
approach that
Yeah.
as the pathologist?
Yeah, I mean, finding anything less than 12 lymph nodes, I think, would put you more into a high risk category. But again, like you said, it may just be the resection and not necessarily reflect that you're missing, positive lymph nodes.
And one other thing that I think is somewhat confusing to many people is the T4 designation based on extension to the free peritoneal edge, when it's through the serosa into the fat, but if it's actually at the edge of the fat. I mean, how does that work exactly today with the T4 staging? That's a little different than it used to be, right?
Yeah, so you want to see that tumor, at the time of looking at the specimen grossly, so not even under the microscope, you want to see that tumor perforating through that serosal surface to indicate a T4
Or we
lesion.
don't want to see that.
Well, yeah, we don't want to see that.
Right.
The patient certainly doesn't want that,
Yeah.
but that's how we want to identify T4. And under the microscope, you may see tumor approaching that serosal surface, but if there's no gross correlation with perforation and it's just within a millimeter, we may call that a radial margin. Some people may call that a radial margin, but you really want to see perforation of that serosa to put you in that high-risk category.
What I take away from our conferences is that there's still variability in the way the pathology specimens are assessed. And that's what causes me a challenge when I get it's clear cut that it's a T3, the nodes are negative, they feel confident that it's 12 lymph nodes, and then they tell me there's a tiny speck of LVI. And I don't know how to put all that information together and make the best decision for the patient sometimes.
I agree, and I think, if we're going to talk about personalized medicine in colorectal cancer, I think that if we provide even one histopathologic feature on the NCCN list that includes, high-risk patients, such as LVI, then the next question becomes, well, what do I tell my patient their risk of recurrence really is? And obviously, there's no correlation. So we certainly don't have data on any of those histopathologic features to say, if you have feature X, you have a 15% risk of recurrence or a 10%. So, we're certainly far away from personalized medicine, I think, in the evaluation pathologically.
And then we need to also kind of incorporate some of the molecular diagnostics today. Unfortunately, we're still pretty early in understanding most of the biology, but at least we know about microsatellite instability. And if a patient has an MSI high tumor, their prognosis is much better.
Yeah, I mean, that's definitely true, I think. So now there's a number of, molecular markers that would be included on as being prognostic in colon cancer. I think the features that I think would have the most clinical utility today would be, as you mentioned, MSI testing and genomic signature, specifically the Oncotype DX colon cancer assay. If we look at some of the other ones out there, there's lots of conflicting data. I mean, we have KRAS mutations. In the Quasar, it showed a higher risk recurrence in patients that had mutations in KRAS. It didn't work out in the PEDAC3 study. We use that primarily now as a predictive marker, as you know, for resistance to anti-EGFR therapy.
Right.
And so it's more an advanced disease. BRAF mutation, the V600E mutation, there's data suggests that it's an independent marker of overall survival. But those patients who are MSI, it doesn't take away their excellent prognosis. So really, we're not really using that as a primary way of determining prognosis. So I think right now we have what I think is a very good way to supplement the histopathologic features, and that would be with genomic signature to help us identify who are truly the high-risk patients in the stage 2s that we should be treating more aggressively.
Right. I think most physicians have a little bit of confusion with the MSI high feature because we all know that people who inherit a genetic defect leading to microsatellite instability or mismatch repair enzyme deficiency and Lynch syndrome, that's bad because they tend to get more polyps and therefore they get more colon cancer. They have a higher incidence of colon cancer on a familial basis. But it's very counterintuitive that once you have that feature and you have a resection, that's actually better. Most patients who have MSI high and come from Lynch families, they're going to be cured with surgery and don't really need additional therapy. So, that's an example where something that's bad to start out with ends up being good in the end, and it's somewhat counterintuitive.
I agree. I think that you have to think about it in terms of genetic risk versus biology of tumor. And in
Right.
Stage 2 colon cancer, you want to be MMR deficient if you want a quote good biology of tumor.
Since our patients have no control over their MMR proficiency, we need better other markers to help us decide who needs chemotherapy, though.
Right. I think we're all pretty agreed on that. Well, that was a great discussion on staging risk factors for stage 2 colon cancer. So thank you, Deborah. Thank you, Darren.
Thank you, Howard.
Very welcome.